Good morning, everyone. Myself, Dr. Dipan Joshi. My seminar topic is on classification of seizure. My moderator is Dr. Ishani Pandey. Definition: seizure. Seizure is defined as occurrence of signs and symptoms due to abnormal excess neuronal activity in brain. Epilepsy is defined as two or more unprovoked seizures without any cause, leading to a clinical syndrome. This is pathology of seizure. There is increase in excitatory neurotransmitter glutamate and aspartate, and decrease in inhibitory neurotransmitter GABA. Seizure is classified according to ILE classification 2010, International League Against Epilepsy. It is classified as generalized seizures, which is further divided into tonic, clonic, absence, myoclonic, clonic, tonic, atonic. Focal seizures. Focal seizure is further divided into simple partial seizure and complex partial seizure. Simple partial seizure without impairment of consciousness or awareness. It is never a part of epileptic syndrome. It is always secondary due to a cause like stroke or tuberculoma. Interictal EEG is normal. Clinical features: there is Jacksonian march in upper limb distal, which moves distal to proximally towards palsy. This is transient weakness of the upper limb after seizures, which is more common in upper limb than lower limb. Aura can include paresthesia and flashing lights. Complex partial seizure with impairment of awareness or consciousness. Most common causes: mesial temporal sclerosis associated with aura automatism and anterograde amnesia. EEG shows temporal lobe pathology. Absence seizures, also known as petit mal seizures. Yes, sir. Sir, same. Absence seizures, also known as petit mal seizures. Age of onset is usually 6 years, which is more common in males. There is sudden brief loss of consciousness without posture control, which regains consciousness quickly. No post-ictal confusion is there. Hyperventilation can precipitate this seizure. Presentation of the child is daydreaming with normal IQ. EEG shows generalized 3 Hz slow spike and wave pattern. Myoclonic seizures, there is sudden brief lactic shock-like contraction. Consciousness is not altered. Rapid onset and cessation is present. There is juvenile myoclonic epilepsy, which is more common in upper limb than lower limb, more common in adolescent age group. IQ is normal. It is triggered by sleep deprivation. Carbamazepine and phenytoin also trigger myoclonic seizures. In EEG, there is generalized slow polyspike and wave pattern. Tonic-clonic seizures, also known as grand mal seizures, there is sudden loss of consciousness preceded by shrill cry. In tonic phase, there is stiffness of body, respiratory arrest with cyanosis. There is decrease in heart rate and BP. After 10 to 20 seconds, there is clonic phase associated with tongue biting and irregular respiration. Tonic seizures consist of contraction of axial musculature of whole body, last up to 1 minute, and is associated with loss of consciousness. Clonic seizure consists of generalized rhythmic myoclonic movements associated with loss of consciousness. Atonic seizures is characterized by sudden loss of muscle tone. Atonia may also be limited, example head nodding or bending. These are some epileptic syndrome. First is West syndrome. It consists of infantile spasm. This is also called as alarm spells. The spasm of neck flexures plus severe mental retardation. Present in child less than 1 year of age. EEG shows hips arrhythmia. Large mountain Himalayan veins. It is associated with tuberous sclerosis complex. Second syndrome is Lennox-Gastaut syndrome. There is slow spike and wave pattern plus atonic seizures and mental retardation is present. EEG show 1 to 2 Hz spike and wave pattern. This is the EEG pattern of hips arrhythmia in West syndrome. It is showing mountain spikes and wave pattern. Dravet syndrome is associated with febrile seizures. Then comes afebrile seizures. There is also developmental delay. Jan syndrome, there is repeated myoclonic seizures. Thank you. These are my reference.
Good morning, everyone. My name is Dipali, and my moderator is Dr. Tanya ma'am. My topic is pharmacotherapy of seizures. Introduction. Epilepsy is a chronic medical disorder, usually resulting in unpredictable, unprovoked recurrent seizures that affect a variety of mental and physical functions. A person is considered to have epilepsy when 2 or more unprovoked seizures occur that cannot be explained by a medical condition. Seizure can be a result of family tendency towards the disease, or they can occur after a brain injury, but the cause of epilepsy is largely unknown. The annual incidence of epilepsy has been estimated at 50 per 1 lakh, with the prevalence of 5 to 10 per 1,000. Etiology. There are several possible causes of seizure. Seizure can be induced because of high fever in children, someone who has a structural defect, or somebody having a genetic risk. A severe penetrating head trauma or injury is also associated with almost a 50% risk of subsequent epilepsy. In older patients, Alzheimer's disease and stroke may precipitate epilepsy. Diagnosis. The physician's main means of diagnosis is to take a careful medical history, gathering as much information as possible about what the seizure looked like and what happened just before they began. The physician should also perform a thorough physical examination, especially of the nervous system, as well as an analysis of the blood and other body fluids. Several laboratory studies are usually included in the initial diagnostic evaluation, such as a complete blood count, blood chemistry profile, liver, thyroid function tests, EEG, and brain study, preferably an MRI. Management. Therapy of a patient with seizure disorder is almost always multimodal, and it includes treatment of the underlying conditions that cause or contribute to the seizure, avoidance of the precipitating factors, suppression of recurrent seizures by prophylactic therapy with anti-epileptic medications, surgery, and addressing a variety of psychological and social issues. Goal of the therapy. The goal of the therapy is to achieve a complete seizure control with a single drug taken once or twice a day without side effects. Approximately 70 to 80% of the patients who develop epilepsy may expect to have their seizure control with an optimal AED therapy. When to initiate the AED therapy? Anti-epileptic drug therapy should be started in any patient with recurrent seizures of unknown etiology or a known cause that cannot be reversed. Whether to initiate a therapy in a patient with a single seizure is still controversial. Patients with single seizure due to an identified lesion such as a CNS tumor, infection, or trauma, in which there is a strong evidence that the lesion is epileptogenic, should be treated. Monitoring of the therapy. Because the response to any anti-epileptic drug is unpredictable, the patient should be carefully educated about the approach to therapy. Determination of the optimal dose is often a matter of trial and error. Monitoring of the serum anti-epileptic drug levels can be useful for establishing the initial dosing schedule. When to discontinue therapy? Overall, about 50 to 60% of the patients who have their seizures completely controlled with an anti-epileptic drug can eventually discontinue therapy. The following patient profile yields the greatest chances of remaining seizure-free after drug withdrawal. A complete medical control of seizures for 1 to 5 years, single seizure type with generalized seizures having a better prognosis than focal seizures, normal neurologic examination including intelligence, no family history, and a normal EEG. Stepwise AED plan for newly diagnosed patients. Step 1. And first of all, this is the approach which we need to consider while selecting the drugs. Step 1, any precipitating factor, for example, a fever in young children, excessive fatigue, alcohol or drug abuse, hypoglycemia and photosensitivity should be identified, and the patient and the relatives must be counseled about their avoidance. The reason for step 2, the reason for instituting AED treatment, the expectations, limitations, and likely duration of the therapy, and the need for the regular tablet taking should be explained. In particular, it needs to be explained that the AED do not provide a cure for epilepsy and have to be taken for a long time. Step 3, patient should be commenced on a small dose of the first line AED recommended for their seizure type. Dose increment should then be made if the seizure continues and the side effects of the medicine do not occur. The strategy should be to gradually increase the dose of the chosen agent up to the maximum tolerated dose if necessary. This table shows us the various first line and the alternative drugs for various types of seizures. For example, in generalized onset tonic-clonic seizures, the first line drugs used are lamotrigine and valproic acid. The alternatives which may be used are phenytoin, carbamazepine, oxcarbamazepine, topiramate, phenobarbital, felbamate, etc. For focal seizures, the first line drug used are lamotrigine, carbamazepine, oxcarbamazepine, phenytoin, levetiracetam. The alternative drugs which can be used are topiramate, valproic acid, tigabine, phenobarbital, primidone, etc. In typical absence seizures, the first line drugs used are ethosuximide, lamotrigine, and valproic acid, while the alternatives used are clonazepam. In atypical absence, myoclonic, atonic seizures, first line drugs are valproic acid, lamotrigine, and topiramate, and the alternatives are clobazam, clonazepam, etc. So the next step which we need to consider is that if the seizures continue despite a maximally tolerated dose of the first line AED, the diagnosis and the etiology should be reconsidered. It may be that the patient's attack don't have an epileptic basis, or maybe the patient is not taking the prescribed medications. Step 5, another first line drug for that patient's seizure type should be commenced and built up to an optimum dose, and the initial agent should then be withdrawn. Step 6, the dose of the second drug taken alone should then be adjusted to optimum as with the initial agent. Step 7, if the seizure continues despite a maximally tolerated dose of all the first line drugs, the next step is to try a combination of the first two line drugs for that seizure type. Example, ethosuximide and valproate for generalized absence seizures. Step 8, if the combination of the first two line agents is also not helpful, then the drug which has been the most beneficial and has the least toxicity should be continued, and the other AED should be replaced by the second line drug. Step 9, if the addition of the second line drug provides effective seizure control, then withdrawal of the initial agent should be considered. Similarly, if the second line agent was unhelpful, then it shouldn't be continued. Step 10, if seizures are still not adequately controlled, then the use of novel AED may be considered. So the conclusion is, the above scheme will generally take a number of months or even years to work through. It is important to follow a treatment plan, and if satisfactory control cannot be obtained with AEDs within 2 to 3 years, and the patient has partial seizures, consideration should be given to surgical treatment. These are my references. Thank you. Yes, sir.
Good morning, everyone. The topic of my presentation is management of status epilepticus. Definition. It is defined as a 5-minute or more of continuous clinical and or electrographic seizure activity or recurrent seizure activity without recovery, returning to baseline between seizures. Generalized convulsive status epilepticus, self-perpetuating generalized tonic-clonic seizure or of a series of generalized tonic-clonic seizures without return to consciousness in between. It has two phases: initial compensatory phase, which is marked by increased cardiac output, blood pressure, blood sugar, and increased blood lactate levels, and a decompensation phase, which includes homeostatic failure. Non-convulsive SE, it is diverse, may range from severe impairment of consciousness to subtle phenomena. Motor manifestations, if any, need careful CNS examination. Refractory SE, it does not respond to standard treatment regimen for status epilepticus. Nearly 40% cases are refractory. Malignant super-refractory SE, it does not respond to a course of anesthetic drugs. It consists of 20% of refractory cases. Aims of management. First is termination of the status epilepticus. Second is prevention of seizure recurrence, then management of precipitation cause, and then management of complications. Diagnostic workup includes, in all patients, we have to obtain IV access, monitor vital signs. Head CT is appropriate for most cases, and labs like blood glucose, CBC, electrolytes, etc. And based on clinical presentation, brain MRI, a lumbar puncture or toxicology panel might be needed. Continuous EEG monitoring should be initiated within 1 hour of SE onset if ongoing seizures are expected. In case of refractory status, general anesthesia should be given. This is the pharmacological treatment of the status epilepticus. The first line drugs are IV benzodiazepines. In case of impending and early status, which includes which lasts for 5 to 30 minutes, IV benzodiazepines are given. Lorazepam 0.1 mg per kg or midazolam 0.2 mg per kg or clonazepam 0.015 mg per kg. Then the next drugs are IV anti-seizure drugs like phenytoin, fosphenytoin, or valproate or levetiracetam. Phenytoin is given 20 mg per kg, valproate 20 to 30 mg per kg, or levetiracetam for 20 to 30 mg per kg. In case of generalized or convulsive or subtle SC, IV midazolam 0.2 mg per kg is given with a maintenance dose of 0.2 to 0.6 mg per kg per hour, or IV propofol could be given 2 mg per kg with a maintenance dose of 2 to 10 mg per kg per hour. In cases of focal complex myoclonic or absence SC, further IV pure anti-seizure drugs like valproate, levetiracetam, lacosamide, topiramate, pregabalin, or other drugs could be given. If the seizure lasts for around 30 minutes to 48 hours, it is established an early refractory status epilepticus. The next drugs are phenobarbital or thiopental, which is given 5 mg per kg and 1 mg per kg respectively, with a maintenance dose of 1 to 5 mg per kg per hour. A seizure, if lasts for more than 48 hours, would be called late refractory status epilepticus. Other medications that could be given are lidocaine, verapamil, magnesium, ketogenic diet, and immunomodulation. Other anesthetics that could be given are isoflurane, desflurane, and ketamine. And other approaches include surgery, VNS, RNS, RTMS, ECT, hypothermia. In case of refractory status, general anesthesia should be given. Propofol 2 mg per kg IV bolus with it could be repeated if necessary, followed by maintenance infusion of 2 to 10 mg per kg per hour. Thiopental 100 to 250 mg IV bolus over 20 seconds with further 50 mg bolus every 2 to 3 minutes until seizure is controlled, followed by IV infusion of 3 to 5 mg per kg per hour. Midazolam is given 0.3 mg per kg IV bolus at 4 mg per kg per minute. It is repeated in every 5 minutes, 3 doses followed by infusion 2 microgram per kg per hour. Along with emergency control of SE, maintenance therapy should be started to prevent recurrence of seizures. In patients known to have epilepsy, the usual anti-epileptic drug can be continued depending on serum AED levels. In patients presenting for the first time as status epilepticus, drugs like phenytoin or sodium valproate used to control the status can be continued as maintenance therapy. Emerging therapies. Inhalational anesthetic agents like isoflurane and desflurane, the attractive features of these agents are that it includes efficacy, rapid onset of action, ability to titrate according to EEG. However, further studies are needed in this field. Ketamine is an NMDA receptor antagonist. Experimental studies have demonstrated synergistic action of diazepam and ketamine in termination of SE. Efficacy in extremely refractory SE has been documented and no cardiac depressant properties noted. Non-pharmacological treatments include a receptive therapy, vagal nerve stimulation, hypothermia, decreased brain metabolism, which is neuroprotective, and electroconvulsive therapy. Thank you. My reference is from Harrison's Principles of Internals.
Just here to observe. Thank you. Ask questions. See if you can. All of you were there yesterday. I think there was a patient who had seizure. So in that case, what would you do? From the to the patient. But are you people were there? So what's your suggestion? Should मैनेजमेंट के लिए क्या करो? इस टाइप का सीजर देखा ना इस टाइप का डिवाइस कैसा सीजर टाइप से your view same generalized math only. Anybody has a different was not math learning, it was something else. Math learning का एक जो है जर्क की मूवमेंट होता है so that is what you need to do. You would have put little bit videos, I think you would have. Okay, tonic क्या होता है समझना चाहिए क्या होता है टोनस क्या होता है क्या होगा बिहेव जैसे कॉन्ट्रैक्शन ऐसे स्ट्रेट ऐसे हो जाएगा कॉन्ट्रैक्शन ओके टोनिक क्या होगा टोनस देखते हो आप वीडियोस का बिल्कुल जब टोनस होता है तो क्या होता है कैसे देखते हो पेशेंट में देखते हो किसमें देखते हो और क्या देखते हो कहाँ देखते हो नहीं देखा कभी नहीं देखा मुझे किसमें नहीं देखा स्ट्रोक को देखे तो ह्यूमन 11 कभी मैंने कहा था लास्ट टाइम कर क्या होता है बोनस बढ़ जाते हैं ठीक है वही उसमें subconscious drive or there's है किसी क्लास में repeated contraction and होता ना मूवमेंट स्ट्रोक में दिखता है इसमें इंक्रीज होता है तो अगर आप वो करते हो क्या कहते हैं नी में देखते हैं पाम में ऐसे करके देखते हैं नी में दिखता है सो टोन इंक्रीज होगा या रिपीटेड जो है कॉन्ट्रैक्शन रिलैक्सेशन जैसे आपने लगाया था ना वो क्या कहते हैं GIF इमेज उसमें पेशेंट को सीजर आ रहे थे, पीपीटी में आप लगा दीजिए, आप लगा है वो पेशेंट को क्या है उसको, आई डाउट उसके लिम्स कैसे ऐसे है। सीजर क्या होता है? The main purpose of doing that people understand how to present it. Also, we have put, I initially put these topics for undergraduate level because these are things that we should know at the MBBS level. Okay. So earlier we were giving you things that was purely psychiatry. We did not ask questions. You are respected. Seizure क्या होता है? Anybody? सीजर तो पता होना चाहिए, सीजर क्या होता है? क्या होता है सीजर की डेफिनेशन है पहली स्लाइड फर्स्ट स्लाइड। क्या होता है सीजर?
increased neural activity of brain leading to silence of voice.
Right. ये increase neural activity of brain leading to ऐसे symptoms। तो ब्रेन की एक्टिविटी ईजी में दिखना चाहिए, ठीक है। जब हम लोग डिसोसिएटेड देखते हैं वो क्या होता है? इसीलिए उसको कन्वर्जन जो बॉडी नॉलेज कन्वर्जन सीजर इज डिफरेंट फ्रॉम कन्वर्जन। ओके, डोंट मेक एन एरर कि अगर डिसोसिएटेड पेशेंट आप एक्सपेक्ट कर रहे हो डिसोसिएट कर रहा है पेशेंट, वो नहीं हो सकता। सीजर में सीएनएस की फायरिंग जरूरी है, वो ईजी में आएगा। अगर ईजी नॉर्मल आएगा तो अपने पेशेंट को ईजी का ईजी नॉर्मल आएगा, फिर सीजर नहीं है तो उसी टाइम पे देखता ना सीजर के टाइम। ओके, इन सम केसेस यू मे सी सम चेंजेस पोस्ट इक्टल आल्सो, बट ड्यूरिंग सीजर देखिएगा हुआ। इसीलिए वीडियो ईजी करते हैं। किसी में अगर रिपीटेड अगर आ रहे हैं तो लग रहा है कि सीजर है कि सूडो सीजर है, तो उसके लिए कौन सा टाइप का सीजर है, तो वो कंटिन्यूस ईजी करते हैं, उसको कंटिन्यूस ईजी मॉनिटरिंग करते हैं ताकि जब सीजर हो तो पता चल जाएगा। ठीक है, सीएनएस में चेंजेस आएंगे, न्यूरल डिस्चार्जेस होंगे, फायरिंग होगी न्यूरॉन्स की, और जो न्यूरॉन्स फायर करेंगे उसके आपको सिम्टम्स होंगे। इसीलिए आप उससे अगर आपको न्यूरोलॉजी आती है, मतलब यू नो व्हाट हाउ ब्रेन वर्क्स एंड यू कैन डिफरेंशिएट बिटवीन डिसोसिएटिव एंड नॉन डिसोसिएटिव। जैसे ये मूवमेंट, ये अगर किसी को ये मूवमेंट हो रही है तो ये इट इज अनलाइकली कि उसको सीजर है। वो क्यों है? क्योंकि जैसे नेक की मूवमेंट के लिए एक तरफ की आपको वो चाहिए, कहते हैं नेक मसल्स कॉन्ट्रैक्ट करनी चाहिए कि रिलैक्स करनी चाहिए, कॉन्ट्रैक्ट करनी चाहिए। सो ऑल्टरनेटिंग आपका राइट और लेफ्ट ब्रेन से तैयार नहीं कर सकता ना, ये होता है। इफ समबडी इज डूइंग supination pronation, so the patients don't know if these kind of movements you see, then they are more towards dissociative. Okay, और complex हो सकती है presentation, जैसे अगर parietal lobe में हो, temporal lobe में हो, तो उसमें आपको definitely presentation अलग हो सकती है। So you need to study these things. These are MBBS level. You don't tell them. सीजर तो आएगा ही आपके पास पेशेंट, कहीं भी हो सीजर का पेशेंट आएगा इमरजेंसी में लेकर कहेंगे आपको क्या करना है। फिर कल क्या कहता है उसमें पेशेंट को क्या किया था? What did you learn yesterday? You had a learning experience there. You saw patient of seizure. What did you do? हम लोग दौड़ देखा क्या होता है, पूछा नहीं आपने कि क्या कर रहा है? How do you learn? हाँ?
I am the other.
लोराज़ेपाम क्या है? बेंजोडाइज़। फिर क्यों दिया लोराज़ेपाम? क्यों दिया? क्यों दिया लोराज़ेपाम? मैकेनिज्म एक्शन है टू प्रिवेंट फर्दर। वो सीजन में काम नहीं करेगा, ठीक है, पर टू प्रिवेंट किसी सीजन क्लस्टर में होते हैं तो डिक्रीज द एक्टिविटी। बेंजोडाइज़पिन सबसे छोटे स्टार्टिंग है, तो वो दे दिया तो उससे कि अगर सेकंड सीजर नहीं आएगा, पॉसिबिलिटी कम है, ठीक है, स्टेटस में नहीं आएगा, स्टेटस के ट्रीटमेंट पे ना आप दे दो, ठीक है, अच्छा प्रेजेंट किया आपने, पर जो है वो क्या कहते हैं, स्टेप 1 स्टेप 2 स्टेप 3 आपने प्रेजेंट किया था ना, वो आप स्लाइड्स ब्रेक कर लो बस, ठीक है, ठीक है, यू टुक दैट फ्रॉम वेयर, स्टेप 2 स्टेप 3 इट्स गुड, जो है ऑटोमेटिकली यही करना चाहिए, हम लोग जैसे मल्टीपल को देते हैं, क्या कहते हैं, AEDs टुगेदर, we should avoid because people have to take it for long period. One of the most common reason for relapse in seizures क्या है? Non-adherence. Non-adherence का major reason है adverse effects, cognitive sedation, etc. If people are coming here, please ask questions, learn, आना है attendance के लिए, काम करना है, तो सीख भी लो ना, यहाँ पे आके पूछो कि ये पेशेंट को क्या किया, कैसे किया, जो लाइव हो रहा है वो देखो, यहाँ पे पेशेंट्स का थोड़ा सा आइडिया लगाओ कि स्किज़ोफ्रेनिया कैसा होता है, डिप्रेशन कैसा होता है, देखो, सब्सटेंस विड्रॉल तो हर फील्ड में, any branch you go you will get substance withdrawal, because ENT you will do an operation and the patient is going to withdraw, तो उसको मिलेगा नहीं, तो आपके पोस्ट ओटी में withdrawal चले जाएगा, कहीं आपको क्या होगा, फ्रैक्चर हो, आपने एडमिट किया, थर्ड डे वो जो है अल्कोहल विड्रॉल चले जाएगा, तो you should withdrawal manage करना, तो आपको नहीं, you will always, any branch you will see patients of substance withdrawal, because they will get hospitalized, they will not get the substance. और यहाँ पे आपको पेशेंट से कहीं पता चलेगा साइकोसिस नहीं है, कितने हॉस्टाइल, कितने वायलेंट एक्चुअली होते हैं पेशेंट्स, इतने नहीं होते, आपकी परसेप्शन, ठीक है, चलो, otherwise it was good, और you have to get well. But if you get topics in which you're supposed to read also, and you will also पढ़ के आना, क्लोनस आप सब लोग मेरे को कल डेमोन्स्ट्रेट करना पेशेंट कैसे करते हैं क्लोनस, क्लोनिक एंड व्हाट इज क्लोनिक, डाउनलोड कल रात को तरीके से और उसको ऐसी नोट्स पढ़ो बता देगा नोट्स तो पढ़ो तो पैटर्न में लिखते हैं गलत बोल रहे हो मैं बोला कि मैं इशारा नहीं करता मैं आगे इतनी एंजाइटी हो रही थी आगे कर दिया ना ना मैं बस वही करता था वहां सब दे दे मुझे रहता था ठीक था पैर के और ऐसे भी कर रहा था कि कॉर्नर दिखा दो करके इसको देखेगा
डायरेक्ट अरे मुझे
प्रेजेंटेशन सब दिया है पढ़ के तो ये बोल के बहुत हो जाता है किसी को क्योंकि हम पढ़ के एक्चुअली किया है सर्टिफिकेट मिल गया 12,000 देखो बहुत आते हैं सोच मुझे नहीं तो और मैंने बोला संडे पकड़ लिया मैंने सोर्स ऐसे गाइड कर रहे ठीक है अगर सर बोल रहे ना सोर्स में मैं ये तो खाई नहीं एडिशन में कट के चार जाती क्योंकि एडिशन तो जॉब एप्लीकेशन है मैं तो बोला से मैंने ना तो बोल रहे मैंने इतने कॉन्फिडेंस
क्या बच्चा बोल रहा है कल पर
तो अच्छे से पढ़ के आई हो अच्छा कोई तो बोलते हैं डिसोसिएटिव
ये तो बहुत क्रिटिकल
ये तो हमसे एकदम माइनस से ऊपर जाने का बोला इंग्लिश
मैं तो मान के खाली एमबीबीएस के सीजर्स नहीं आते तुम्हें अरे पहले इंट्रो देखा फिर हमारी होती है आप बताइए नहीं आते हमें नहीं आते बात सर मुझे वो तो होता है कि और बता
अब क्योंकि मैं पेंसिल वाला वो कोर्स तो किया नहीं है तो प्रिंटिंग में थोड़ा 6 बार प्रिंट किया वो छुट्टी में फाइनली सही आ
इसलिए बोला ब्लैक एंड व्हाइट की जाऊंगा
कर दिया मैंने और उसके बाद वो दे दिया अगला उसने एक आधा पेन से अभी पेपर तो मैंने उसमें बना फोन नंबर तो सबका सेम है एड्रेस भी सब उसमें बनाना शुरू
के नाम में मेरे ऐसे यार इसकी फोटो दे देता है इसको लेने में भी शर्म आ रही है मुझे इतनी शर्म आ रही है इतनी शर्म आती है लेने में
मैं तो मुझे पता और भी खींचेंगे लेकिन
मेरे पास निकल रहे थे राउंड पे जाओ राउंड करोगे मेरे को देखा नहीं मैं देखा ये भी बढ़िया